Hello there, this is Professor Mark Whiteley from the Whiteley Clinic. Today I'm going to talk to you about some new research from the Whiteley Clinic that's about to be presented in New York, although by the time you watch this video it will have been presented in New York, and it'll also be available on a preprint server for the whole world to see. Varicose veins, most people sort of understand it's the valves not working, and most doctors in the UK and around the world just really look for the simple big veins. There's 150 other veins on each leg called incompetent perforator veins, which at the moment most doctors just ignore. They either don't address them at all or say, oh, don't worry, we'll just put some foam sclerotherapy. And the research shows that doesn't work. One of the reasons we get such good results at the Whiteley Clinic, and we see so many patients from these other vein clinics and these other practitioners in network hospitals who don't actually treat varicose veins as their primary workload, so they don't really go to the meetings, they don't understand it. One of the major reasons is they don't actually understand or see the incompetent perforators. So I'm giving this talk today to you, and I'm going to give some diagrams and then show you the research and a very nice video at the end to actually show how these perforators work and to show why our theories are correct. And this is one, as I say, one of the major reasons that the results from the Whiteley Clinic tend to be so much better, especially in the long term for low recurrence rates. So to help you understand this, we're going to look first of all at this diagram here, which is a cartoon of the leg. And as you can see, just there's a right leg, and on the inner aspect on the calf, I've just drawn some varicose veins. Now, if we sort of peeled that away and just looked under the skin, what we'd see is this. We'd see the varicose vein, and we'd see on the next one here with the arrow, this is where the underlying great venous vein, that long vein you can see going from the ankle to the groin, when that refluxes, that leaks into the varicose vein. And that's what most doctors understand. And you see I've sort of ghosted it out because that great venous vein is in the next layer down, and the varicose vein, as you can see, is the bright blue. However, what most doctors ignore is that varicose vein is also almost always being fed by an incompetent perforator. And that second red arrow that's on this diagram, you can see that incompetent perforator coming up from below. We've now stripped away the next layer, so you can see the great venous vein, but you can also see the incompetent perforating vein coming through this level. This is called the AC2. These red arrows here show the great venous vein as it lies on the inner aspect of the thigh, and this here is the incompetent perforator once again coming up through from below. If we peel away the next layer and we look right down into the muscles, these are the deep veins. And the arrow at the top, that's the leaking point in what's called the saphenofemoral junction. That's where blood is falling out because the valves aren't working into that great venous vein, which has been removed. But you can see here at the bottom, the incompetent perforating vein is coming straight off the deep veins. And this is the difference in anatomy. The incompetent perforating veins come straight through the muscle, perforate through the muscle, hence the name perforators, and come all the way through into the varicose veins. This diagram shows what happens when you put a catheter, like a heating catheter, either laser radio frequency. We'll talk about those at another talk. But this, you can pass the catheter up to the groin, and then under local anesthetic, you can see once you pulled it down, you shrivel that great venous vein away. And many doctors will then tell you that that is all you need to do. And as you can see in this next diagram, they just put this foam sclerotherapy into the residual vein on the surface, or some people pull it out, and many people now just either leave it or put foam into it. The difficulty is, and on this final one you can see, they haven't closed the incompetent perforator vein because they don't believe it's important. So this final diagram shows what happens when you put one of these heating probes into the perforator itself. And this is a process called the TRLOP technique, the transluminal occlusion of perforator technique, or the trollop technique, which was invented in 2000 by myself and Judy Holdstock. Now we're going to just go over and look at the sort of why people don't believe perforators cause a problem. And of course, the biggest reason is that doctors are a bit lazy. It takes a lot of time and effort to do a scan to find a perforator vein, and they wouldn't be able to get away with these cheap 2-minute scans or 5-minute scans if they looked for all 150 perforators, so they just ignore them. The second thing is, of course, they're difficult to treat. And if they're difficult to treat, it's much easier for a doctor to say, oh, don't worry, they don't need treatment. And you as a patient will believe them right up till about 1 to 2 years after your treatment, when all your veins are coming back again. And that's when you need to come and see us if you went somewhere else first. We're going to now look at these other diagrams. So this first diagram is what a lot of what's called hemodynamic surgeons believe happens in perforators. And the book here I've shown you, this is by Claude Franceschi and Paolo Zamboni. And these doctors have written this book, which is wrong, but I need to show you this for you to help you understand why people haven't understood perforators correctly. On the left side here, you can see the basic layout of what happens in your leg when you are walking. So the little black arrows are showing the pressure of the muscle onto the deep vein, and the blue arrows are showing that the blood squirting up to the heart. And then the vein that's running on the right side of it, that's your great venous vein, blood is also rushing up that. And then I've highlighted and I've done a little blowout in the yellow circle showing what they believe happens between the two systems. So if you look at the middle diagram on the left, you see this very fast arrow going up the deep vein. That's they've got V1 written there. And your slightly smaller arrow in the superficial vein on the right. And the idea is because there's more blood flowing faster up the deep vein, they say the Venturi effect sucks blood in through the perforator, and therefore the perforator is always competent. However, if you now look at what I wrote up in the Understanding Venous Reflux book, which I published in 2011, I pointed out that this is actually incorrect. Although in the book itself I used the diagram of a ferriliquid bottle where when you squash it with your hands you can see not only does fluid flow at the top, but if you drill a little hole between your fingers and squash it, of course you get the same amount of blood rushing out at very high velocity. And on the diagram you can see here on the slide, what we actually find is when the muscle contracts and you put all that pressure on the muscle, the blood squirts everywhere it can get out. And if the perforator vein valve isn't working, of course it squirts straight out and causes the varicose vein. And we've seen this many times causing varicose veins, leg ulcers, etc. And if you don't close that vein individually, then you end up with recurrences or problems. The trouble is, of course, this is our theory. We've proven it in many times by saying, look, our patients are getting better, but many doctors still don't believe it. So what the research that we've been doing is trying to find patients who only have one incompetent perforator, or the rest of the veins, their deep veins, their truncal veins, all their other veins are working, and then looking to see exactly what's going on in their legs. This picture here on the left side, this patient has, these aren't the worst varicose veins in the world because they are only from one incompetent perforator, but you can see the discoloration on the lower leg, a few thread veins there and the discoloration, and there is a lumpy varicose vein there, but it's quite small. But on the right side, it's much easier to see because the right side shows the infrared spectroscopy. Now, the way infrared works and why we use it so much at the Whiteley Clinic is the orangey color is the color or is the heat that you get from muscle. It's the sort of generalized heat that you would expect from a living person. And the closer to white, so through the lighter oranges, then through the yellows, all the way up towards white, the brighter it gets, the hotter the area is. Now, blood that is going from the outside inside, normal venous blood, you can't see because it's cold going to hot. But if you've got incompetence, if you've got valves that aren't working, hot blood from inside the muscle jets out, and that's what heats up the skin. It causes the varicose veins, inflammation, etc. And we can pick up that hot blood coming out by yellow patches. And you can see on this infrared, you can actually see a big patch of yellow right under where those varicose veins are. Now, this next slide shows what we found with the ultrasound. With the ultrasound, we can see there is an incompetent perforating vein coming out through the muscle and into that area. So we took this patient, and this is the same patient. We lay them flat, because when they're lying flat on a bed, there is no gravity, there's no reflux. The veins should not be refluxing out because there's no gravitational difference between the heart and the foot. So therefore, that's why your varicose veins always feel good and your veins feel good when you're lying flat, because if you're lying flat, there's no gravitational pressure pushing the blood against valves, and therefore the valves, it doesn't matter if they have given way or not, because the blood is just going to seep back towards the heart. Now, if Franceschi and Zamboni and all these other doctors are correct, when this patient then starts exercising the leg when lying down, you should see nothing, because all of the blood will be shooting up, and because it's going up the deep veins, it should be sucking all the other blood in, and therefore there won't be a problem. However, if I'm right, then what will happen is when the patient starts moving the leg, hot blood will jet out from deep through the perforator and into the varicose veins, even though there is no gravity to do so. So let's look at the infrared video here. So this infrared video, this is the patient lying here, and you can see she starts lying, and you can, if you watch the outline at the top of the purple, you can see her muscle contracting as she's moving her leg at the ankle with her foot going up and down, and you can slowly see the redness going to an orange in the middle of the frame, and that is the blood pumping out through the incompetent perforator. And here we are now getting about halfway through the video, and you can see very, very clearly the blood coming out through the perforator and into the varicose vein. And as we go on through the 10 or so pumps, you can see how much of that venous blood has pumped out from the deep system. And here, as we get to the end of the video, you can see that bright yellow, not only the vein going across the leg, but one starting to go around the side. So what we've shown in this video, and what we're presenting now and writing up in research papers, is the mechanism of action of incompetent perforator veins is not gravity. It's not when you stand up. There may be some evidence that that also has an effect, but the main is when you're walking, when you're moving, when you're wiggling your foot. That's when these perforators cause a problem. And that's why most doctors don't understand them. Because when they look for perforators, they stand the patient up, do a scan and say, is it leaking? That's the wrong time. They should be looking at the patient when they're moving, which of course is really, really difficult to do if you're using duplex ultrasound. You need to be very, very specialist to do that. And that's why we train our vascular technologists at the Whiteley Clinic to be experts at finding those. Once we've understood the mechanism, we now know that these incompetent perforators will cause problems if we don't treat them. Therefore, these doctors and clinics who are offering endovenous laser or radiofrequency foam but not offering to find the perforators and treat them are going to end up with bad results. It all comes down to the science.